Hi, welcome to FASD and Youth, What Defenders Need to Know. My name is Reba Omer, and I am delighted to welcome you today on behalf of the Mid-Atlantic Juvenile Defender Center, housed at Georgetown Law's Juvenile Justice Clinic and Initiative. NJDC is one of the National Juvenile Defender Center's 9 regional centers. We provide training and support for attorneys defending youth in DC, Maryland, Virginia, West Virginia, and Puerto Rico. Today, we welcome defenders from across our region and across the country, and we thank NJDC for their support. In hopes of reaching even more advocates, we have decided to record today's presentation. We plan to make this recording available along with several handouts after the training. Now, I'm excited to introduce you to today's speakers. First, we have Dr. Larry Burd. Dr. Burd is an internationally renowned expert in FASD. He is a professor at the University of North Dakota, where he trains medical students. He's a clinician, and he's the director of the North Dakota Fetal Alcohol Syndrome Center, which provides diagnostic services, treatment, and training. Finally, you'll hear from Diane Smith-Howard of the National Disability Rights Network. Diane is a litigator with more than 26 years of experience in juvenile and education law. Her work at NDRN focuses on conditions for youth with disabilities in the juvenile justice, child welfare, and education systems. Thank you all for joining us today, and I'll hand it over to Dr. Burd to get us started.
Drinking during pregnancy increases your risk for having a fetal alcohol spectrum disorder. These are common. 5% of first grade students in the United States have a fetal alcohol spectrum disorder. So that means that 1 out of 20 babies is born with it. 1 out of 20 kids of any age level have an FASD. It's a lifelong disorder. It changes across development. And in a sense, drinking during pregnancy causes damage to mostly a single organ system, the brain. This produces in children a series of very complex problems, and that's what we're going to go into today. So let's start with drinking during pregnancy. So as the mother drinks, alcohol enters her stomach, enters her bloodstream, crosses the placenta into the fetus. So the mother and the fetus have essentially identical blood alcohol concentrations across the entire time of each one of these exposure episodes. So if the mother is quite intoxicated, so is the fetus. If the mother is drunk enough to pass out, the fetus has an equivalent amount of alcohol. Next slide. So one of the keys to what we're going to talk about today is figuring out how to establish that exposure took place. And it's helpful, I think, if you start at the beginning and give some thought to how you're going to do this, because it's much easier to do it right the first time than it is to try to have to go back and fix it. So we begin with a single question. When was your last drink? If a woman is pregnant, we risk stratify that based on who we can see on the slide. If their children are of any age, it tells us at least as best we can, when the last episode of exposure took place. We go from when was your last drink, we'd ask some other questions, then we would begin to talk about before pregnancy. And we try not to ask more than one exposure question at a time. So we would ask prior to pregnancy, how many days did you drink? Some questions. What is a drink? Some questions. How many drinks on the day did you, on a drinking day, do you have? And then we would ask, when did you find out you're pregnant? Re-ask those questions again. So that's a basic way to look at exposure. I think the keys here, try not to ask more than one question on exposure at a time, and that will clear this up. Next slide. Drinking during pregnancy causes damage to the fetal brain. Every episode of drinking is an episode of brain damage. This slide here portrays what happens. So the brain on the bottom is from an animal that was exposed to saline during pregnancy, essentially a placebo, normal brain. The brain on the top is a brain exposed to a single dose of alcohol. And all of the dark shading are cells that are in the process of dying. So every episode of drinking is an episode of brain damage. The brain damage then preferentially affects some areas over others. And I think of brain structure as modular. So the use of alcohol during pregnancy interrupts the functions of memory, attention, expression. And I use a stoplight as a model for how this works. The parts of the brain that regulate impulsive behavior, as near as we can tell, essentially unaffected. The parts of the brain that have rule-governed behavior, the red light, those are quite impaired. The parts of the brain that use what we always talk about, think before you act, before you do that, that also is a part of the brain that is quite damaged. So this leaves us with a group of people who have a lot of impulsive, poorly thought out actions that continue to occur across the lifespan. Next slide. I just want to talk briefly about this because it's essential that we get some kind of handle on the magnitude of this problem. So this is a fictitious state. They have 78,500 births a year. At 1%, that's 758 cases of fetal alcohol spectrum every year. Just multiply by 5 to get a higher proportion. But in any event, after 20 years, there's 15,160 cases of FASD in this particular state. Somewhere around 1% will be diagnosed. 99% of these people are not correctly diagnosed with having a fetal alcohol spectrum disorder. Next slide. So, prenatal exposure, brain damage, produces impairments. And at the time of diagnosis, we can begin to look ahead and see some of the upcoming risk factors. High rates of abuse and neglect, extremely high rates of mental disorders, school problems, early prolonged involvement with the legal system, high rates of substance abuse, and decreased likelihood of living independently. Next slide. So we have the prenatal exposure to adversity and the postnatal exposure to adversity. And very often in these families, there's additional complexity that results from their contact with child protection, the foster care system. At our center, the child who holds the current record for foster care placements when he came to see us had already had 31. We have large numbers of children who are in their 8th, 10th, 15th foster care placement. And it's important to understand that that is an indicator of the complexity of taking care of these children. And the fact that the foster parents who are trying to take care of them don't have enough services, enough support to be able to do that. Next slide. I think it's really important to consider some recent data. We have demonstrated at our center that having a diagnosis of fetal alcohol spectrum disorder is strongly associated with increased numbers of adverse childhood experiences. And I think you can see that here from this slide. The blue line across the top are people with fetal alcohol spectrum disorder. As the number of adverse childhood experiences increases, the likelihood of that person having an FASD increases. And you can see that by those three groups at the bottom. But people with FASD are much more likely to have many adverse childhood experiences than the control population of people who don't have FASD. Next slide. Many of these adverse childhood experiences are, of course, experienced in very disruptive, dysfunctional settings. My original thinking on adverse childhood experiences was that children tend to mostly be able to deal with those, and then those ACEs, as you're aware, show up later in life and cause a withering array of health problems. It's now clear that these adverse childhood experiences are gifts that keep on giving across the lifespan. Next slide. It, I think, is clear that these early environmental experiences really matter in children's lives. It's one thing to be removed from a dysfunctional home, to have difficulty in school, but it's quite another to be living in 7, 8, or 10 foster homes and 5 or 6 or 7 or 8 schools. So as we see these children at 12, 13, 14, 15, 16, and we look backwards in time, we can begin to better understand the problems that they're having. And much of this is biology more than behavior. Next slide. For those people who are dealing with these children, it's important to understand that the natural developmental course of fetal alcohol spectrum disorder is one of increasing complexity over time. And in part, this is because we expect more from children as they get older. They're spending more time in different settings. They have decreasing amounts of adult supervision. And so we have increased complexity. It's important to think about that, especially for children and adolescents who are involved in the legal system. Next slide. Often I get referrals for children, and people say, I want to know if this child has fetal alcohol spectrum disorder or ADHD, intellectual disability, anxiety, or depression. Almost certainly that's the wrong question. The question that I believe is correct would be better, does this child have FASD, and what other comorbid, co-occurring conditions do they have? And in fetal alcohol spectrum disorder, problems with attention, learning, vision, hearing, sleep are just extremely common. And so it's not ADHD or FASD. It's not intellectual disability or FASD. It's FASD and how many of these other conditions are also present. Next slide. By now, I think it's common. FASD most frequently, most predominantly is damage to the developing brain. So when we think about which children might have FASD, most of them are not going to have short stature. Most of them are not going to have abnormal facial features. most of them are going to have characteristic features of brain damage. The kinds of children, adolescents that you see all the time in your particular practice. Next slide. What's important about this, I'm not going to read this whole slide, but what's important, I think, are a few things. One, FASD is a familial condition. The younger children in the sibship are more likely to have FASD, and it's more likely to be the more severe form of it. It's a generational problem. So often when a child is diagnosed, there will be adults in the family, grandparents sometimes, who also have FASD. One of the main points I'd like to make here is that when we see these children, we often don't get to see their parents, especially their mother. And if you look in the middle here, you can see that the mother's risk for premature death is increased 30 to 40 times, depending on the location in the study. So we have a huge increase now in maternal mortality in the United States and across much of the world. And it seems clear that one of the reasons for this is that women are drinking more, they're crossing this threshold where health problems predominate, and many of them are dying from it. Another, right below the maternal mortality, is a indicator of early life. So about 15% of the kids that come to see us have had a traumatic brain injury. Most of these occurred in the context of abuse. I'm not going to relate the common story, but with drugs, alcohol, substance use, goes a lot of ill-tempered, violent people, and this places children at great risk. Next slide. When we think of somebody with FASD, what are we thinking about? First, we're going to look behind the face, brain functioning. Disorders of attention, concentration, distractibility, extremely common. About 50% of these kids have that problem. Depression, 10 times more common. Fetal Alcohol Spectrum Disorder, the most common cause of intellectual, the most common identifiable cause of intellectual disability in the United States. Learning disabilities, substance use, all greatly increased in people with FASD. So what I'm trying to present here is a picture of a substance which causes broad, mostly non-specific damage to the developing brain. So what can FASD look like? Well, like almost any function that the brain can perform. So we see children with FASD who've had strokes, epilepsy is not uncommon, cerebral palsy. We have kids with FASD who have different types of brain malformations, and about any of these neurodevelopmental disorders can be comorbid or co-occurring with FASD. Next slide. One of the things that's hard for us to teach, we spend a lot of time on this, is to be able to look past the face and be able to look past what we consider behavior for impairments. And I have a little example I often use. So those of you that have heard me talk before. So if in the 3rd grade, I develop a behavior problem around reading, and the teacher begins to get concerned about this, and the more they encourage me to read, the more belligerent and defiant I get. This goes on for a while. Next year, I get a new teacher. Somebody eventually figures out that the reason I'm doing this is because I don't see well. So they spend about $250, about $1 a school day. I get some glasses. They have accommodated for my impairment. The likelihood I'm going to continue to have that problem is greatly decreased. The vision problem is still there, but we have accommodated for that impairment. And that's really a key in FASD across development for these children. Next slide. How will we identify these kids? In the neonatal intensive care nursery, early intervention, special education, foster care, in the correction system, in residential care treatment centers, we should have a very, very high level of suspicion about fetal alcohol spectrum disorder. So in April, in the journal Alcoholism, Clinical and Experimental Research, we're publishing a validity study of this questionnaire, 31 items long, easy to use, can be filled out by parents, foster parents, grandparents, quite a range of people. And it gives you an idea of whether any of these areas are areas of concern. So it's a validated tool. It'll be published in the peer-reviewed literature. It's easy to use, takes 10 or 11 minutes to fill out. So I think you have an opportunity to begin screening, begin thinking about this. Next slide. When you're dealing with someone and you have the same problem that has persisted over and over again, one of the things you should think about is how likely is this willful manipulation? So here's an example. At 2, somebody who's irritable, impulsive, requires a lot of attention, same problems at 8. Same problems at 14, same problems at 20, essentially the same problems at 24. The only thing that has really changed here is the environment and our expectations for this person. So when you are confronted with a problem which is just persistent over time, has no particular payoff, no particular benefit for a person, I think it's good to ask yourself, why would we not be better off to consider this an impairment as opposed to a behavior? Why would this not be a person who's likely to have a fetal alcohol spectrum disorder? And I think you'll find that often that's a good question to ask. Next slide. When we're crafting interventions for people, treatments, it's common that we think about separating behavior from impairment. We think about visual impairment, hearing impairment, cognitive impairment. But very often what we should see is a lot less behavior and a lot more impairment. Because as we begin to think about impairment, alterations in brain function, we can accommodate for those impairments, and to a degree, we tend to get rid of those. We diminish their importance over time when we accommodate for them. Next slide. As you know, these problems are highly variable. As attorneys, it's important, I think, to keep your eye on the fact that these peak levels of functioning are not particularly useful in fetal alcohol spectrum disorder. They are not reproducible when we need them. They arrive without any warning. They leave without any warning. And they cause great confusion because on the day or two that you know all your multiplication facts, people become suspicious if you can't do multiplication after that and begin to think that you're jerking them around. If you're able to accommodate and meet the needs of probation sometimes, but not other times, then we often draw the wrong conclusions from that. So neurocognitive functioning is highly variable over time. These peak performances that show up in psychological testing are not good indicators of ability. And I think being in the business we're in, we all know that it's the worst days that define how things are going to go for much of your life. Next slide. So it helps, I think, to consider this like strings of Christmas tree lights. You got a box of them. Nobody just puts them on the tree. You plug them in to see if they work. You put them on the tree. Sometimes they work. Sometimes they go out. You go over and you wiggle them a little bit, they come back on. You turn around, some that were on go off. So if you think of these as a string of lights for memory, attention, recall, facial recognition, how well you do math, on and on the list goes. And you become aware of the fact that sometimes these randomly just go out. This is very similar to children who have suffered a lot of abuse in childhood. They have this same problem. Sometimes they'll be thinking about something and it just disappears. They're unable to capture it anymore. You see this a lot in reading, and spelling, and math. And as children get older and get involved in junior high school, get involved in the legal system, we often mistake this evidence of brain damage and dysfunction for behavior problems. And that has very, very complicated outcomes, adds to complicated outcomes for these children. Next slide. One of the things that's helpful to understand is that as this brain is damaged prenatally prior to birth, damage often occurs to the frontal part of the brain, the frontal lobes where these executive functions are. One of the big executive functions is to allow a person to keep control over the strongest of emotions from a little part of the brain called the amygdala. And when the amygdala gets turned on, we have a constrained set of options: fight, flight, freeze. So many people with this just take off running during times of stress. Some become paralyzed, can't move. Some fight. When this occurs over and over and over again, we often draw the wrong conclusions from this. Next slide. So when you think about how this looks, I deal with a lot of kids going into residential care, and they come to see us. They have different names for this problem: rage episodes, storms, behavioral episodes, blow-ups, but essentially it's the same thing. The frontal lobe functioning is impaired. They get these huge surges that activate the amygdala, produce these behaviors of running away, fighting, being unable to perform, loss of memory. And as a result, these children have these explosive outcomes. Now, one of the things that we spend a lot of time doing is trying to help people understand that during these episodes, talking almost never helps. What we need is some calm distance away from these kids, but following them around, talking to them all the time is almost never going to be helpful for them. Next slide. FASD as I'm sure you see all the time, looks a lot like this. Most of the kids that end up in these legal systems have very high rates of learning disabilities, past adverse childhood experiences, current neurocognitive dysfunctions. Shows up in their sleep, shows up in their toilet, shows up in their regulation of temper, shows up in their ability to form social relationships. Next slide. So I don't know if it's possible to say enough bad stuff about FASD, but I'm going to try. So in the United States, fetal alcohol spectrum disorder is the leading identifiable cause of these problems. I'm pretty sure almost everybody on this call is involved with most of these systems. As we go along here, I'm going to quantify this, but I just want you to think about the massive numbers of kids with FASD in these settings, and the fact that 99% of them are undiagnosed. So if somebody asks you, have you seen somebody with FASD? I think the appropriate response is, I may not have seen them, but they have certainly seen me. Next slide. The data on health system utilization by people with FASD, very impressive. Very high rates of emergency room use, inpatient, outpatient services. The mental health system is a huge service provider for people with FASD. So what we need to do is to begin to increase our level of suspicion for FASD, to systematically screen. And my own opinion is that no child should be in any kind of court setting, a legal setting, without somebody having specifically addressed whether or not they have FASD. It'd be ideal if the judge would routinely do that, but I'm hopeful that you will begin to think about that. So these are some useful indicators. Next slide. We captured every study ever published in all languages on ADHD, intellectual disability. Go down the list. We averaged out their prevalence, and as you can see, in people with FASD, 50% have ADHD. You can look on down and see this. So FASD is very commonly associated with, very likely causal for many of these other conditions as well. Now, let's just look at this a slightly different way. Next slide. Think about this. Psychosis in childhood, rare, but it's 24 times more common in people with FASD. ADHD, common, 10 times more common in people with FASD. Intellectual disability, 22, 23 times more common. On down the list we go. So it's important when we think about this that we take a wide angle look at FASD, because these things play predominant roles when you get involved in residential care and the legal system. Next slides. Next slide. One example, 43% of juveniles have given a false confession. When you spend any time around these children, these adolescents, you can see how that's possible. Next slide. Probably not much we need to say about that. I just point out again that when somebody says, have you seen somebody with FASD? The better response is, I may not have seen them, but they definitely saw me over and over again over the past however long your career is, because this is not a new problem. Next slide. I'm not going to go through all of these, but I have tried to take some specific impairments, translate them into some of the things that you should be concerned about. And I'm sure that the people who are going to speak next will be able to flesh this out and put this in more detail. I just want to point out a recent example. So I was involved in talking about a case of FASD for a person, and they kept wanting to know who entered the room, where they stood, what happened. And this person had horrible visual spatial impairments. And as they went along, the story kept changing. It's just not something they can do. They just can't recreate what happened there. And I think it's very important as an attorney to know that. Next slide. I am appalled by the number of forms that people in the legal system sign. People with FASD in general have greatly diminished reading comprehension skills. They have decreased listening, oral comprehension skills. They don't write well. They don't spell well. They don't do math well. They don't understand mathematical concepts well. All forms in these legal systems, somebody needs to run them through some kind of readability scale so we have some idea of how complex they are to read and understand what is contained within those. Same thing's true in court. Next slide. One of the keys in your work is going to be looking at IQ as an index of impairment, looking at adaptive behavior as an index of impairment, realizing that one is not a better indicator of impairment than the other, both equally important. And when we get ready to try to figure out whether someone has intellectual disability or not, we should not be doing that based on IQ. We need to do it based on IQ and adaptive behavior assessments. One not more important than the other. But recall that intellectual disability 23 times more common in people with FASD than in controls. And in the United States, FASD is the most common identifiable cause of intellectual disability. Next slide. A special note about anxiety. During development, as children begin to enter adolescence, their typical developmental trajectory, spending more time away from their parents, being less communicative with their parents, more prone to impulsive decision-making, not thinking through consequences, diminished ability to identify problem peers, increased risk of substance use. FASD exacerbates all of those problems. A particularly troubling combination is attention, impulsivity, and anxiety. It leads to a lot of really rash decision-making. And I suspect a lot of times this happens before children get access to an attorney to help them work through the implications of some of this decision-making. Next slide. This has been a problem for 40 years. I've been writing about this for 20 years. Canada probably has some of the best services for FASD in the world. And their attention to FASD is quite limited. So we want to keep in mind about 5% of the people born every year have FASD. Birth through 18, birth through 20, whatever the cutoff is there. We have huge numbers of these people. 99% or more of them are not identified. Where are they at? Well, they're in the systems that you folks work in. Next slide. The implications of FASD in the legal system, in my opinion, are enormous. The complexity accompanying FASD in the legal system, just very difficult to grasp. Almost at every level in these systems, children with FASD, adolescents with FASD do more, they just function poorly. They have more interaction with the legal system. It tends to be more complex. They have more adverse outcomes in the legal system. And we do a great favor for these kids if we think about FASD, we screen for it, we try to identify it, because it presents a biological basis, brain damage acquired during pregnancy, to be able to explain some of the consequences and to help identify some of the important protections that are needed by these children. Next slide. I think this sort of sums it up. I just want to call your attention to this bottom left-hand slide image. Damage to the fetal brain during childhood. We can see that, we understand it, we empathize with it. 13, 14, 15-year-old who is doing the same thing over and over again. We rethink this. Instead of saying you have abnormal brain functioning, we say you must be responsible for your actions. You have to have consequences for this. And things go downhill for these children and adolescents after that. Next slide. Often comes up, well, we would do this, but we can't figure out what benefit a diagnosis would have, because we're already doing everything we would do even if they had fetal alcohol spectrum disorder. And that's just simply not true. First, a diagnosis identifies a mother with a lot of complications, current and future. We have an opportunity, if we identify these children early, to prevent a huge number of adverse childhood experiences. More relevant to this population or to the people, to our audience, we have an opportunity to prevent a substantial number of secondary disabilities: school failure, substance abuse, contact with the legal system, entry into residential care, foster home place failures. And the earlier we identify children with FASD, the sooner we can begin diagnosis-informed care. And I think that's pretty self-explanatory. We take care of people with FASD, and they are different from people who have just visual impairment, people who have just anxiety disorder. So diagnosis-informed care, very important. Next slide. So what do I think will make a difference? Well, first, screen every child. Parents have a lot of money. Parents don't have much money. Parents are married. Parents are single. Parents have a partner. Screen everybody. Second, when you're confronted with difficult people, step back from behavior and think about putting your arm around impairments as a way to better understand what's going on. The diagnostic criteria vary, some from place to place, so we didn't spend a lot of time on that. But as you become more experienced with thinking about FASD, then figuring out how you're going to get an evaluation, diagnosis, very helpful. And I think by and large, people can begin to figure that out. FASD, lifelong disorder. This woman that we diagnosed in her 80s with FASD, and she pretty much summarizes the lived experience of people with FASD, particularly on the more severe end, and the absolute devastation this has had in her family. Next slide. This was a fellow that was charged with, I don't speak legalese, so charged with murder. Very complicated set of circumstances. But his attorney, in talking with him, could not make heads or tails out of what actually happened at the time that this murder supposedly took place. And he couldn't really get a sense from this person about just life in general. So he referred him, and here's what we came out of this. So I learned a couple things from this person. One, over my life, I've seen a lot of kids. And I had seen some previously who had alcohol dependence, developed alcohol dependence very early in life. I thought all of them were an isolated circumstance until I saw this guy. And by age 6, he was drinking every day to prevent withdrawal. Since then, I've come to have a different viewpoint of these guys. And I think the reason we don't see very many of them as adults is that they generally are all dead by then. But when we went through this, we found this guy had intellectual disability. He read to 3rd, 4th grade level. He had had pretty much all the bad stuff that can happen to him. Tremendous physical and sexual abuse took place. So what did they know about this? Well, I think virtually everything on here came as a surprise. He had a huge stack of records. He had taken the sophisticated psychological, psychiatric tests. Not possible he could have read those things. Long, detailed discussions with various people who had evaluated him was clearer, I think, that this was a fantasy interview that they had. So sometimes these will be very complicated, and I can't help but think this is going to be extremely valuable to you in a court setting, to be able to share with people how we got to this point, what this means, and how this is going to affect our future planning. Next slide. So thinking ahead, next. We talked about FASD and normal adolescent development. It exacerbates the developmental trajectory of adolescents in a negative way in most cases. If you already have learning behavior problems, psychiatric difficulties, substance abuse problems, these are exaggerated by that. Very often the presentation that people have, because of their lack of sophistication with nonverbal communication, lends an appearance to them of belligerence, defiance. Some of the kids who have more experience in these legal systems have acquired this language and demeanor of a hard guy. But when you ask them about it, you sit down and spend time with them, you can see this is quite shallow. They really don't understand what's going on here. So next slide. I want to reinforce a problem that we just heard about. So talking is overused. It's over-relied on. And we have to help people understand this, that often it simply does not work. Doing more of it is not helpful. So talking and anxiety, when oral comprehension is poor, when you have low IQ or diminished IQ, you're impulsive, lots of talking, repeated explanations, detailed explanations, alternative explanations, not really helpful. So what's some alternatives we could use? Well, first I want to demonstrate, next slide. In a situation like this, you do not need more information. You simply cannot deal with the information you have. More talking simply overloads people more. So we have to help people understand to step back from that, provide some alternative choices. A couple things we can do. We can decrease anxiety. We can try an alternative method using pictures, graphic storyboards. We can wait till a different time to explain it. But when confronted with a situation like this, you do not need more information. Next slide. So in general, what do we want to do? Well, the purpose of the affidavit is to give you a basic working understanding of FASD in the legal setting. We have to go a lot slower. Pictures very helpful. Memory unreliable and highly variable. Anxiety is a big problem. In incarceration, on probation, and residential treatment, if we use positive behavior management, we're going to have better outcomes, fewer explosive episodes, dramatically fewer episodes of escalating behavior. I think as attorneys, you're going to have to be able to present these comorbid conditions and the impact of these comorbid conditions with fetal alcohol spectrum disorder. These offer a look forward and give us some idea of what we're going to have to do in the future to meet the individual needs of this person, how best to accommodate for their disabilities. Respite care, going to be very helpful if you're looking at foster care or similar interventions like that. Next slide. I just want to touch on guardianship. Perhaps Diane or Debbie will come back and talk about that. Guardianship, hugely underutilized, very helpful for these kids, especially in bridging into adult life during a crucial time until we can get things sorted out and get them set up. Guardianship can be just very helpful. Next slide. In thinking about these people, one of the things we have to think about, I believe, is that they are very complicated to parent, very complicated. So for their birth parents, their adoptive parents, foster parents, whoever, I think learning about fetal alcohol spectrum disorder, understanding how this presents itself, how knowledge translates into improved understanding and improved outcome, very helpful. I provided 2 handouts to go with the affidavit for you, one on education, one on legal systems. I'll turn it over to my good friend and able colleague. Who's on mute.
Diane, I think you need to unmute your phone if that's what you're using for audio. We can't hear you yet. Oh, maybe now. Can you try again?
My phone says that you can hear me.
Okay, now we can. Yes, thank you. Go ahead.
Good. Yeah, sorry about that. I'm using a creative number of technology solutions here. My name is Diana Smith-Howard. I'm a managing attorney at National Disability Rights Network, which is the membership organization for the protection and advocacy system. There is a P&A in every state and territory, so there are 57 of them, and there is assuredly one in your state. P&As are publicly funded law firms that represent people with disabilities. So my job here today is to talk about the other service systems that may be available to provide services to your client and their legal rights in those systems, probably quickly, but happy to follow up. And also what P&As can provide in terms of assistance to juvenile defenders, because we frequently do individual consults and support for attorneys. And you should not hesitate to contact your P&A, and the contact information is on the last slide. I'm going to start quickly by sharing a story which I think really encapsulates the things that both Debbie and Dr. Burd were saying. One, I had a client, this is a real kid, who in 3rd grade, an African-American child with FASD, was left alone after school during detention next to the candy closet, which is a closet in the classroom that the teacher had used to frequently get positive reinforcement candy for kids during the school day. So he was left alone with the candy closet, which was unlocked. So inevitably, he took some candy out of the candy closet. And when asked about it, he produced the wrapper and admitted that he had done it. There was no guile about it, no remorse. It's just a thing that happened. Well, immediately the school district made a request for juvenile justice referral and suspended him from school. He was only in 3rd or 4th grade at the time, and they said he needs to learn a lesson. He clearly has criminal behavior, criminal intent. This is a kid with FASD who had impulse control issues, communication issues, and a lack of remorse, and the kind of gullibility that Barry talked about. So anyway, his parents came to the IEP as it turns out, he was adopted by two professional parents who were married, who were white, and they went to the IEP meeting. They presented a neuropsych evaluation, and suddenly he was a child with a developmental disability as opposed to a child who needed to be taught a lesson with pre-criminal behavior. And I think it's really important to think about that, both in the juvenile justice context, but also in the school context. It's the same issues. The school district expects, just as Dr. Burd had mentioned, that the child grow out of it by 8th grade. A child with developmental disability is not going to grow out of it at any point in their life, but they're expected to just suddenly become competent pre-adult individuals as they head into middle school and high school. The school district needs to provide for kids with disabilities a manifestation determination review before they can suspend or expel a child. That's part of the IDA and Section 504. What we find with these kids is often they are not identified under either special education or Section 504, and then they're often informally removed, meaning that the school district doesn't call it a suspension or expulsion. They send the child home, they put him on a shortened school day, they say we don't know how to meet his needs, so we're going to put him on tutoring, 1 to 5 hours per week. There are a number of ways in which informal removal occurs. And so one of the most important trigger points there is to make sure that the child actually is evaluated for special education and Section 504. The difference between those two services is special education is provided to children who require some sort of alteration in the manner in which school services are provided. So they need special services as opposed to accommodations. Section 504, which a child can be eligible for both at the same time, Section 504 provides accommodations and modifications similar to those required by the ADA. So if a child just needs more time to finish a test, they would have Section 504. If they need a different test or they need special education services to help them access that test, they would have an IDA or special education IEP. The way that works for these kids is they often have a very complex mixture of strengths and weaknesses. And as Dr. Burd said, they also often have good days and bad days. So that makes them just ripe for school discipline because the school district will find they're not eligible because they're really, really powerfully strong in certain areas because that's not the part of the brain that was impacted. And they have tremendous deficits in other areas. So the school district will say, well, he does so well in reading and so poorly in writing, he can't possibly really be that way. And so as a result, he can't be eligible. It must be he's lazy or he's unmotivated or he has a focus issue. And he may also have a focus issue. That's entirely possible. But so kids are often found ineligible. And the same way, and probably this comes up in juvenile justice context as well, the fact that a child can have a very good day behaviorally can change the way the school district sees him for discipline. Well, he was great on Monday. He's having a terrible day today. Clearly, he either has an unstable home life, and we need to look at getting him into foster care, or he has a willful disobedience problem. The reality is that it's a very variable disorder. It's actually very similar, I find, to representing kids with traumatic brain injury, which also can have that kind of diffuse impact. So you have tremendous eligibility problems. One of the wonderful services that the IDA provides, and one of the incentives for moving a child from Section 504 into special education, if that's appropriate for the child, is what are called transition services. Starting at age 16, a child with a disability who's eligible for special ed is supposed to get a complex series of services to help provide that child to move to post-school activities, whether you're talking about career, post-secondary ed, and so forth. And it's supposed to be individualized and based on the needs and desires of the child. So that's a great time, if they haven't been properly evaluated, to really insist on an evaluation that will look at their future. And one of the things I think is tremendously important there too, and I'll talk about this more in a minute, is that many of these kids have never been able to dream about their future. So just the very act of asking them, what do you want to do or be, and that there are services provided to help you with that, can make a world of difference in terms of keeping that child engaged in school. Vocational rehabilitation services is another resource that the PNA and the CAP agency in your state can help access. Many of these kids are not found eligible for voc rehab because, again, they're not thought of as a kid with a developmental disability. They're thought of as a bad kid, and bad kids don't qualify for voc rehab, but DD kids do. And so, again, that's where a proper evaluation can be very helpful. One of the things that we see a lot with these families in particular is a lot of kids are either in foster care, in the child welfare system, or living with kin because their parents have had difficulties. So they are often either truly homeless or they're couch surfing. A lot of the older kids have burned out of that kinship placement and they're staying with friends around the street. The McKinney Act is intended to help kids with disabilities and not access the school district that they were supposed to be in before they became homeless. So I'm happy to share information about that, but that's a great way to keep a kid anchored to their home school and most importantly to the caring adults that they've formed relationships with. Because many of these kids don't have caring adults in the other parts of their lives, and maybe that one teacher at school or that coach was the only person who connected with them. So that's incredibly important. Also, there are child welfare protections. There are actually right now a number of major lawsuits reforming the child welfare system. Many of these kids are wards of the state. I actually refuse to use the term foster care for kids with disabilities because in our experience, usually kids with disabilities are in residential placement or they're in group homes. They're institutionalized. They're not, kids who are wards of the state are not in family-based foster care, unfortunately. So child welfare is really the term I use, or wards of the state or county. So one of the things that they have a right to is permanency planning, meaning there needs to be some movement to get them out of that setting and into a permanency plan within 1 year. Oftentimes that is not the case. So it's good to know that those protections are there and how to access them. Supported decision-making, that's the next slide. One of the things that we see, Dr. Burd mentioned the need for guardianship, and I think that's incredibly important. But I think one of the things that is important to think about is looking at it from an individualized basis and looking again, because many of these kids have tremendous strengths and tremendous weaknesses. So what do they really need help with? Do they need a limited guardianship just to address financial issues or educational issues? Can they make other decisions, especially if they're using peer supports? So limited guardianship or conservatorship is better than a full guardianship when possible, so that the child can retain as much liberty as possible and learn some of those decision-making skills over time, particularly because a lot of these guys are going to need repetition. They're going to need time to really learn some of these adult living skills, and so the more time they have, the better with that appropriate oversight. I'm sure you all know about this in great detail, but when there's a lack of parental involvement, especially if the child is a ward of the state, there's usually a DHHS caseworker or whatever it's called in your state, a child welfare worker. They are often grossly overloaded and they do not attend IEP meetings. They often are not participating in institutional care meetings of various types. And so there, you may want to look at other options like a next friend, a GAL, or for kids for whom it's appropriate, emancipation, because you may not be able to get in contact with a caseworker to actually get that decision making, and the child may not be competent. So when accessing services outside the juvenile justice system, it might be appropriate to consider whether a next friend or GAL should be appointed for this child. In some states that happens automatically, in some states it does not. Next slide. Again, what we were talking about before in terms of levels and how kids earn their way out of juvenile detention or residential treatment. These kids are not particularly adept at the level system, and they often aren't able to complete the various services and requirements of probation residential treatment or juvenile detention. So they end up staying in institutional care longer. And so one of the things that we're really looking at, and this is again a good way to, a good opportunity to partner with the PNA, is looking at the overuse of institutional care. If a child has been in a residential treatment center or a group home for a longer period of time than seems right, I would ask about permanency planning. I would ask, what is the state doing to move this child into a more home-like community-based setting? And then advocating for community-based alternatives, because many of these kids can do very well in therapeutic foster care. And again, if you think about them as children with a developmental disability, as opposed to bad kids or criminal kids or kids with conduct disorder or whatever they're being called, that's when I think it's helpful in terms of getting them access to things like therapeutic foster care. Another thing we see a lot of is many of these kids are placed with kin, grandparents, aunts, uncles, and those the kinship care placements are often not given appropriate support. So can the child receive Medicaid-funded therapy? Can the grandparents get respite care through Medicaid in your state? Can you get access to the DD services for this child? Because those are all the things that are put in place to help kids with a developmental disability make it in the community. And again, that's a place where your PNA and other advocacy organizations may be able to be helpful. And this may be beyond what you can do as a juvenile defender, but it's useful to know that these services are out there. If you have a kid, especially a teenager, who can have access to transition services, voc rehab services, therapeutic foster care, and or support for their kin, and that the kin get respite care and support and therapy as well, that can make all the difference in the world, particularly around preventing recidivism. So those are some of the things to keep in mind. Next slide. School discipline hearings. This is, I'm sure, very similar to court and probation. So I'll just spend not very much time on it. As we talked about previously, school district staff often talk to the child faster and faster and faster, the more upset they get. And then they get a very bad result. The child may flee down the hallway and then be seen as a flight risk or seen as disrespectful. They may sometimes strike out at school staff. That is always ill-advised, but quite common. They often don't have communication skills to present their side of the story in a level-headed, meaningful way. In fact, they don't have communication skills often to present any sort of story. They are very gullible, and school district staff know sometimes that they're the kid to lean on. So because they'll sing about the other kids involved in the incident, the kids that were actually probably much more at fault than my client usually is, but my client is the one leaned on to tell the story and name the names. So that's something I think to watch out for. They often are not able to demonstrate remorse or respect. So what you would like at an expulsion hearing is a child who shows up in a collared shirt and pressed khakis with a letter in his hand that demonstrates remorse for whatever it was, a family with a neuropsych evaluation that shows a diagnosis. The child is able to sit through the hearing and make eye contact with the school board members. These guys, it often is not the case. For one thing, they may not have a parent with them. And if they do, they may seem disrespectful, they may curse. In school board hearings, expulsion hearings, they're usually members of the community, often members of the local business community. They're not education professionals. And so that sort of presentation is tremendously helpful. So whenever possible, I don't bring my kid to the discipline hearing. If that's going to be an issue, I assume that's the same sort of thing that comes up in court. If the child is not going to be particularly helpful, sometimes it's best to just do that letter ahead of time and submit it and bring in whatever parent or guardian you have available who can do the best possible presentation. So that's school district discipline hearings or expulsion hearings. I think that pretty well covers it, but I'm happy to answer any questions about that. Next slide. Next slide. Eligibility for developmental disability services. In many states, there's a wide array of services for kids with developmental disabilities. And in many states, they are not available for kids with FASD because they're based on a clear IQ cutoff. And as is often the case, these kids have relatively higher IQs, but they have huge variability in their adaptive deficits. So impulse control, the ability to organize, anything that involves the frontal lobe, organizational skills, money, budget planning, all those things they may actually test significantly below their tested IQ, their full scale. So they may not be found eligible for DD services. So there's a couple of things you can do there. One is you can advocate for, or through someone else, perhaps the PNA, advocate for that individual child, and also advocate as a policy across, a systemic argument at the state legislature or wherever else it needs to be to add FASD to the developmental disability eligibility categories so that it's clear that if someone has a diagnosis of FASD, they can receive these services if they have a certain adaptive deficit. Some states have, instead of making an FASD exception, they also just provide for an analysis of adaptive deficits for anybody, which I think is probably a better policy. But if the child is found eligible for DD services, then they can get those services through adulthood. And that can be tremendously helpful in terms of keeping them connected, especially if they eventually become homeless or have other sort of wobbles as they proceed through adulthood, which is often the case. It's good to have that connection to a service system. In addition, if you're eligible for DD services, you're much more likely to get vocational rehabilitation. And then I'm going to wrap up pretty quickly here. There's two things that the PNAs are doing right now, which I think are helpful. One is that some PNAs have created a phone application that young people can use to do their transition planning. It's particularly helpful for kids who are highly mobile or kids who have reading issues because it can be done with a screen reader feature. It leads them through a series of questions and helps them create a transition plan. In addition, 10 PNAs are currently involved in a Ford-funded project on misincarceration, where they have agreements with local probation or juvenile defender organizations to refer kids who are misincarcerated. They're kids who are have entered the criminal or juvenile justice system, but they're really just kids with developmental disabilities that need services. So if you are in one of those states, basically what happens is those kids, when they enter the system, get bumped over to the PNA for representation so they can skip the system altogether. So we're hoping that that will take hold. Here is the information for how to contact the PNA in your state. I believe that Maryland and Virginia are likely represented here, and Maryland, Disability Rights Maryland, Disability Rights Virginia. So I think that's all I have for right now. I'm happy to answer